was walking through the Crown and Bridge department the other day and saw a case that had a sticker on it that says no room. And that kind of like no room at the hotel, it means no room. But we'll take a look and I'll show you exactly what no room means. Here's the impression that the doctor sent in. Okay, so the patient was biting all the way together. We can definitely see through the tray. Patient was in maximum intercuspation. Wow, that wisdom tooth is really close to the back of that tray, but they did get together all the way, so that must not be fully erupted. And then here is the impression of the preparation. And we have a second molar, lower second molar. We have a pull right there, it looks like. So if I take a look right along here, that pull, I've noticed in my impressions when I see something like that, it's usually pretty typically caused by fluid trying to escape an area. And then a little bubble over there, away from the margin, so probably not a huge deal. That could probably be filled in a little bit. In fact, let's look at a solid model for this. There's that, what looks to be that pull as we spin this around on the lingual. Looks like that can be probably cleaned off pretty easily. Boy, this is life on a lower second molar, isn't it? We're having to over taper the distal because the head of the handpiece is hitting the teeth across from it. And then to not whack this tooth, we end up coming back here and making sure that we're able to clear the burr away from that tooth. And we get that kind of thing. You can see how the tooth was probably sitting in there as the mandible starts to turn upwards, and the tooth is kind of at an angle. And so that's, certainly not probably going to win any awards for a prep, but all things considered, and we don't know the patient, it's certainly doable. And you can see pretty clearly that we can identify most of the margin except for right there, but it looks to be a supragingival margin, even though there might have been a little fluid from the patient's tongue movement or something like that. When we look at the mounted model, this is about the angle that we're able to see, right, in dentistry. I mean, if we've got the patient's cheek and we're trying to pull it away and we look in here, and it's very easy to see that we have enough room here between the opposing tooth and the buccal cusp. And that looks good. And we say, all right, we're done. We've reduced enough. The doctor did prescribe a Brux or crown. Really good choice for a lower second molar if the patient won't accept gold. And so you look at it and go, yep, plenty of room. All right, let's go ahead and send it in. And then at the lab, of course, we're able to pour it up and see a view that the dentist couldn't see. And that is from the lingual. And you can see that we have less than 0.5 millimeter of room there between that opposing tooth and that lingual cusp. And it's always the lingual cusp. The lingual cusp hanging down on the upper and the lingual cusp on the lower that is under-reduced, because we simply can't see that from any view in dentistry until we strip the cheeks and the soft tissue away. I mean, here you look at it now and you go, oh, that's clear as a bell. But you never get that view when the patient has their cheek still attached to their face. There's no way to be able to see that. And so it's a difficult thing. And so when a technician asks me, why would a dentist do that? I say, you've never actually tried to visually see this yourself, have you? So last week we were doing a lower second molar and we brought 10 technicians into the room, and they all had a chance to sit down and take the intraoral mirror and pull the patient's cheek away and try to see over there as it gets flooded with saliva and shadows, and they were able to see that you aren't able to see that. And so they have a little more empathy for us now. But my point has always remained the same. I mean, why even take the chance that this is going to happen? As you are probably familiar, on my burr kit, we have certain depth cutters that will make sure that we have reduced enough. And the most conservative one we have is this 0.6 millimeter one for Bruxer restorations. And again, 0.6 millimeters is not a ton of reduction. I mean, look at that. In fact, let me compare that for you to what every company and manufacturer has asked for PFMs for the last couple decades, and that's been the 2 millimeter depth cut. Even that doesn't look like a ton, of course, when you put it on a tooth it looks differently, but that 0.6 millimeter one, it's really simple. If we're doing a Bruxer crown on, say, this second molar, we can take the 0.6 millimeter depth cut, and especially on the lingual cusp tips, I'm going to hold it at a 90-degree angle, so right above it, and here, boom, I'm going to drop this in 0.6 millimeters, and here, boom, down 0.6 millimeters. It's a self-limiting depth cut because it won't go any deeper than that shoulder right there, so you just kind of push it into place. In fact, for bruxer, you could put a couple ones on the axial. You put one on the buccal too if you want. Certainly put one in the central groove. We definitely need one there. And then I'm just going to take my 856-025 burr, or maybe my 379 football burr. Now just whatever fits is what I'm going to go back here with. If you really wanted to play it safe, or if you're doing something else like Emax, we would use a 1.5 millimeter depth cutter. And it's simple. We're just going to take this and put a couple 1.5 millimeter holes on the top of the tooth, and then we're going to reduce that until we don't see the holes anymore. And it's simple. I mean, how much, if you're doing a central incisor, I get it. You can see it directly. There's no cheek in the way. That's fine. But if we're doing a lower second molar, why not put a couple holes in the lingual cusp and the central groove to make sure we have reduced enough? It just avoids this kind of thing, because right now, the choices are we got to adjust the opposing and mark it in black and have the dentist do the same, and that's fine. It's not a big deal. But then if the crown is still a little high in occlusion when he puts it in, if the doctor adjusts this, he could make that bruxer crown too thin, and it would be one of the very few single unit bruxer crowns that would actually fracture. It's just so much easier to put holes in the top of the tooth, and I get kind of impatient about it, because it's not like I'm asking you to pick up a 40-pound weight and run around the block with it on your back. It's just a matter of putting a couple holes here, and then there's no guessing. You almost don't even have to pull the cheek away and look. You certainly don't have to put bite registration or wax here and have the patient bite together and try to interpolate how much space you have. So even if you want to skip all the anterior teeth, when it comes especially to first and second molars, I just think there's no better way to do this than put a couple of known depth cuts into the occlusal surface of the tooth. And if you're doing Emax, for example, use your 1.5 millimeter depth cutter, put some holes in here, the central groove, 2 there, 1 in each lingual cusp, the buccal if you want to, and then just reduce following the contours of the original tooth, and reduce until you don't see those holes anymore, and you're guaranteed of having enough reduction. A guarantee is a great thing, especially when it comes to occlusal reduction, and especially when it comes to saving yourself a phone call from our laboratory or having to adjust the patient's opposing enamel.